This program is brought to you by Emory University.
Good morning, everyone. Thank you for being patient with our IT issues that we had this morning, but we are online and ready to go. This morning, our speaker is Rahul Patel. Rahul is a native Texan. He did his medical school in San Antonio and then was a resident here at Emory. And we are honored to have him as a second-year Emory Fellow. And he will be talking to us today about mitral valve prolapse.
Thank you, Dr. Coley. I appreciate your introduction. So today I just wanted to speak about mitral valve prolapse. There's actually been a couple of presentations related to this condition on some of the fellows and grand rounds. So this one is a little bit more all-encompassing. I've learned a lot about the condition in the last year and a half. So my objectives are the following. I want to describe two clinical cases of mitral valve prolapse with associated mitral regurgitation that had different levels of ventricular dysfunction. I want to discuss the diagnostic criteria, the pathophysiology, the clinical features, as well as the complications of mitral valve prolapse. And I want to review the echocardiographic classification of MR severity, as well as strategies for the management of severe primary mitral regurgitation. So I have two cases. The first one I'll start with the history. So we have a 39-year-old male with a history of dupuytren's contracture. Interestingly, had prior bilateral spontaneous pneumothorax status post two VATS procedures more than 10 years ago and recent tobacco use. So he actually was just bothered by his hand. Went to his PCP's office for the evaluation of the dupuytren's contracture. His primary care doctor listened to his heart and he was incidentally noted to have a new heart murmur. Upon further questioning, denied any symptoms whatsoever. No chest pain, shortness of breath, exercise intolerance, palpitations, dizziness. Worked in a desk job in the construction industry, so he was still able to walk a couple of miles without any difficulty or inhibition whatsoever. His medical history, so because of no significant chronic conditions, was not on any medications, and his surgical history notable for the two VATS procedures a while ago at this point. Social history, he did pick up tobacco in the last 18 months. It should be 1 pack per day, which is 1 pack a year. And his alcohol use, social, a couple of glasses of whiskey every few days. The family history, we thought it was non-contributory. He said that his father had surgery on one of his heart valves. He thought it was his father's aortic valve, but he was clear that he was not on anticoagulation and did not have a redo surgery at the point of our conversation. So not very clear which valve or whether it was contributory or not. In terms of this patient's physical exam, normal vitals, normal height at 6 feet, looked good, no acute distress, walked well. His cardiovascular exam is notable for a 3 out of 6 holosystolic murmur at the apex, no jugular venous distension noted, no lower extremity edema. And so labs and EKG also pretty unremarkable. He had normal renal function in the lab and a normal BNP. His EKG shows a normal sinus rhythm with an incomplete right bundle branch block. And so his primary care doctor actually sent him for a transthoracic echo because of the murmur he heard, which is just a great move. I'll start with a transthoracic echo. On the top left, we have a transsternal long axis 2D image, and you can see when it's zoomed in, you can see a prolapse of the P2 scallop with associated leaflet thickening. When we go to color Doppler, you can see that there's a severe mitral regurgitation with a eccentric anteriorly directed jet, and zoomed in, you see that closer. The other takeaways on this peristernal long axis is that he had a dilated ventricle. His end systolic dimension is 4.7 centimeters, and his EF is now 50 to 55%. This is its initial echo, so the first one we have on him. On apical views, you again see the mitral regurgitation with the eccentrically directed jet. And when we try to alias, we get an MR radius of 1.7 centimeters. And you'll see on the CW profile that the murmur from the mitral regurgitation is holosystolic in nature. So the patient, in terms of his transthoracic echo, he had likely severe degenerative MR that originated from a severely prolapsing posterior leaflet. He also had ventricular dysfunction with an EF of 50 to 55% and an end systolic dimension of 4.7 centimeters. So he was ultimately referred for a TEE as a second step. We'll start with the 0-degree pictures, and you can see that we can already see the prolapse of the P2 scallop. And when we put color, you see the very eccentric jet. I'm going to go up on the angle and show the next pictures. On the bicon view, you can see the P2 is almost overhanging. And you see the eccentric jet that's present. And then as we continue to the 90-degree view, again, we're seeing the P2 prolapse. There's some P1 involvement too with the very severe MR with eccentric jet. And then on the outflow tract view, again, we see a very similar thing where you see prolapse with a severe MR. We have a 3D view right here, and you can see that there's prolapse involving the P2 scallop. So the impression of the TE was that the patient had severe MR that was holosystolic, emanating from the prolapse of the P2 scallop of the posterior leaflet, and there was some P1 involvement too. Importantly, there was no flail. So if you look at the top left image, the chordea remained intact, and the leaflet is turned towards the ventricular side as opposed to towards the apical side. So no flail yet. And the second case is a case that I saw a couple of months ago in Valve Clinic. It was a young male, 29-year-old male, who was referred to Valve Clinic. He had a known diagnosis of prolapse as well as mitral annular disjunction. The picture to the right is a stock image, but the patient looked very much like that. He had a medical history of this undifferentiated connective tissue disease. He had very profound pectus carinatum, just like the patient on the right. He had hypermobile joints, had a lanky appearance, and had a BMI that was low, was in the 16s. Despite him being only 29 years old, he was edentulous. He broke all of his teeth through daily use and had implants, and he also had multiple bone fractures. So his prolapse was actually identified at the age of 18. They noticed a very like marfanoid appearance, and then they noticed at that point a mid-systolic click. Ultimately, he's had multiple echoes on transthoracic echoes. He's only had mild to moderate MR, and then on a transesophageal echo, the most MR that was ever documented for him is moderate. Some other parts of his history, he had non-sustained VT on a Holter. It was 3 to 4 beats, but it was there, and also had sinus bradycardia as well as orthostatic hypotension. Now, this patient, interestingly, unlike the other, was quite symptomatic. He had, a couple of years ago, he could walk 3 miles in the park. At the time of my interview, could really just walk 100 to 200 feet. The max he could stretch himself out to was 500 feet, but then he said he would have to rest the entire day after that. He also had symptomatic palpitations as well as orthostatic intolerance. Now, I say that he had a marfanoid appearance because he actually had a genetic testing panel that was negative. So he has no fibrillin mutation that was noted. Some other things that are important for him is his thoracic aortic size was normal, so no aortic root dilatation. And he also did not have any family history of connective tissue disease or anyone that had an appearance like his. His medications were relevant for metoprolol succinate, 25 milligrams. That was really started because of the NSVT that was seen in the Holter, and this patient has not had surgeries. In terms of his exam, he was bradycardic. His heart rate was 44. His blood pressure was 110/74. The big things is he was tall, he was slender, his BMI was 16.5. He was edentulous with dental implants in place. And in terms of his cardiovascular exam, he had an early systolic click followed by a blowing murmur at the apex that we thought was nearly holosystolic, but it was not fully holosystolic. And he clearly had pectus carinatum. On his extremities, he had hypermobile joints. He was actually able to bend his fingers backwards and like touch his forearm. Did not have any sort of lower extremity swelling. He did have some cherry angiomas on his skin. In terms of his EKG, shows sinus bradycardia with early repolarization changes. So we had pre-existing echoes for him. I'll start with a transthoracic echo. And what you see in the TTE is you see bileaflet prolapse, but his MR is really just, mild, not significantly there. This shows the prolapse right here, where we're looking at 7 millimeters above the mitral annular plane. And on apical images, again, you can see you can see prolapse, but there's just not that much MR present with rest. This patient had a normal EF, 60 to 65%, as well as normal LV size. His end systolic dimension was 3.5 centimeters. The last takeaway here is he has a feature called mitral annular disjunction, which is better seen in the transesophageal echo, where you see that the posterior leaflet of the mitral valve inserts into the left atrium rather than into the typical annulus. These are some TE pictures right here. I'll want to point out the fact that his MR is dynamic. When his blood pressure was lower with a systolic in the 90s, we're going to see the bottom left picture, where you just see mild MR at the 80-degree view. But when his blood pressure increased to more than 100, the severity of the MR increased, and you can see what's closer to more of a moderate MR with multiple jets. And just that reflects the dynamic nature of MR, especially in prolapse. So overall, the patient had bileaflet MR, prolapse with at least moderate MR that was dynamic and had mitral annular disjunction. His mean gradient was only 1 at a heart rate of 60. Showing some 3D images, you can see bileaflet thickening that's consistent with Barlow's disease. And then this is 3D with color. And when we try to alias and get PISA, his PISA radius was 0.6 centimeters, which gave an ERO of 0.15 centimeters squared. The last thing I want to point out too is the CW profile, where you see that the murmur from the MR was not holosystolic, it was mid to late systolic, unlike the prior patient. So overall, this patient had symptoms, but had a normal ventricle and only had moderate MR during TEE. So I just want to now talk about mitral valve prolapse. Prolapse was first described by Dr. Barlow in 1966, and he noticed a phenomenon where patients had a mid-systolic click followed by a systolic murmur. The prevalence today is thought to be 2 to 3% of the general population having prolapse. And prolapse is the most common valvular abnormality amongst all issues. It's also the most common cause of severe isolated MR that requires surgical repair. The estimate is 7.8 million people in the US have prolapse based off that 2 to 3% prevalence. And there's an equal gender distribution. So that's important because in the 1980s, when echo was still a nascent technology coming up, there was this epidemic of overdiagnosis of prolapse. And so at the time, they actually thought that 5 to 15% of the population had mitral valve prolapse. And it was most predominantly found or thought to be in teenage girls, where some studies showed 38% of young teenage girls had prolapse. And this was based off the erroneous assumption that the mitral valve was planar shaped rather than saddle shaped. So when they were echoing patients, they saw what they thought was prolapse and they had heard vague symptoms. So they had an overdiagnosis of the condition. And the other thing is prolapse was initially seen in patients who were very sick and hospitalized. So there was a much stronger association at the time with heart failure and stroke and atrial fibrillation. That risk was lowered with the Framingham cohort study in 1999. So that leads to our current understanding that mitral valve prolapse is an important condition. It affects 2 to 3% of the population, but the course is quite heterogeneous. There's many people who will have prolapse and be asymptomatic for their entire life. And there's some that have severe MR or severe LV dysfunction who have a high risk of mortality. So it's hard to predict how someone will respond. You have to do serial monitoring. The anatomy is an important one, and that's what has led to our current rate of diagnosis. So the Levine group in the late 1980s actually discovered that the mitral valve has a saddle shape. The other way to think of it is like a Pringles chip, where the anterior and the posterior elements are the most superior, so they're concave up. So when you look at an apical view, it is normal to see the anterior and the posterior elements of the valve being above the mitral annular plane. That is not abnormal. And that's why you can only, on a transthoracic echo, diagnose prolapse on a peristernal long axis view. So if you look at a long axis view, the leaflet that you have the best visualization is the posterior leaflet. And so that's really the only one that should be used in TTEs. It's fortunate because the P2 scallop is the one that's most commonly associated with prolapse. So we can see it again on long axis views. This is a good example of that in a peristernal long axis, where this patient has prolapse of the posterior leaflet with a bulge into the left atrium during systole. And so the definition of prolapse is the following. It's a patient who has single or bileaflet systolic displacement greater than 2 millimeters superiorly from the mitral annular plane into the left atrium. This systolic displacement can be associated with or without leaflet thickening. So the classic form of prolapse is the one where you have thickening of the valves leaflets more than 5 millimeters, and that's associated with the worst prognosis. Patients who don't have the associated thickening have what's termed non-classic prolapse, and it's still not very clear, is this even a normal variant or is this actually on the form of prolapse or not? But the big thing is a greater than 2 millimeter systolic displacement into the left atrium. As I previously said, the scallop that's the most frequently involved is the P2 scallop. There are 2 forms of prolapse. The first one that I'll talk about is myxomatous degeneration, which is also termed Barlow's disease, and this is the classic form of prolapse. This one is most commonly bileaflet, and what happens here is you have leaflet redundancy and thickening, which leads to elongation of the cords through a lot of stress, as well as dilatation of the mitral annulus. Again, Barlow's is more commonly bileaflet and more commonly affects younger patients, like the 29-year-old I showed earlier. And the mechanism is that you have proteoglycan accumulation within the spongiosa layer. The second form of prolapse that is described is called fibroelastic deficiency, which is the non-classic form. Sorry, this is Barlow's right here. Fibroelastic deficiency basically leads to thinning of the leaflets as opposed to the thickening that you see in Barlow's. And so when you have thin leaflets, you ultimately can, again, have some redundant tissue. The important thing about fibroelastic deficiency is it more commonly is single leaflet and affects the posterior leaflet, predominantly the P2 scallop. And this can be associated with flail leaflet. Fibroelastic deficiency typically presents at higher age rather than younger age. And so pathophysiologically, prolapse is associated with dysregulated collagen. There's some research in terms of the TGF-beta pathway. But when you have significant prolapse of leaflets, you ultimately put a lot of strain on the chorda. And so what can happen is the chorda have more and more work to do as the degree of prolapse increases. And ultimately, you may predispose yourself towards chordal rupture, which will lead to flail. So this is demonstrated here, where prolapse in general is type 2 primary MR, which is excessive leaflet motion. And when you ultimately put too much strain on the cords rupture, and then you get flail, where the focal segment of the leaflet moves into the atrium or concave up during systole. Flail is a prognostically poor sign. It is associated with worsening MR, worsening heart failure, as well as sudden cardiac death and AFib. And it's also one of the signs that a patient has severe MR. So in terms of diagnosing, we always start with a transthoracic echo. That, as we spoke about earlier, we use the personal long axis view, which sees the P2 scallop well, but unfortunately does not give us great visualization of other segments. So this may miss the diagnosis. It also may undercall the degree of MR because the jets are oftentimes very eccentric for prolapse. If you have high clinical suspicion, or if you should always send a patient for TEE. So it's an important second step for patients with prolapse. The benefit of TEE is the following, is that you basically are able to visualize each segment very well. These are directly from the ASC guidelines, and as you change the angle, you will get different visualization of different scallops. You're also able on TEE to create the 3D surgeon's view. MRI is an important technology in diagnosis of MR as well as prolapse for the following reasons. First of all, it's highly sensitive and specific, up to 100%. It also does two things. It quantifies volumes very well. So you can determine the severity of the MR, and you can also have a pretty good assessment of the left ventricular volume as well as the left ventricular systolic function. The other thing that MRI does well is it looks at fibrosis. So you can get an assessment for late gadolinium enhancement of the leaflets as well as the papillary apparatus, which can help risk stratify for patients who may have high risk for ventricular arrhythmia, which we'll speak about later. A Holter monitor can be helpful for similar reasons. It can help determine if the patient has atrial fibrillation as well as either PVCs or ventricular tachycardia, which are high-risk features. There are two forms of prolapse, or two causes of it. The most common one is primary or non-syndromic prolapse. So this is a patient who just has prolapse with no extra cardiac disease. The genetics of this are very poorly understood, but the thought at this point is that we don't know much about the genetic association. There is a form called autosomal dominant non-syndromic prolapse, which is associated with a gene called DCHS1, which is related to the cadherin family of fibroblast protein. So most patients have primary prolapse and have no extra cardiac manifestations. There is a secondary or syndromic form of prolapse, which is closely associated with connective tissue disorders. The most important one to note is Marfan syndrome. So Marfan syndrome, as we know, is autosomal dominant and is related to the most commonly the fibrillin-1 gene. It can also be associated with FBN2 gene. The diagnosis is made based off the Ghent criteria that looks at elements such as cardiovascular pathology, including aortic root dilatation or aortic dissection. There is musculoskeletal involvement that is assessed as well as ocular involvement. Amongst patients who are Marfan positive, the prevalence of prolapse is quite high, and it's higher than the other two conditions I'll mention. The range that's been described in studies at anywhere from 20 to 91%, But in a meta-analysis, the median prevalence of prolapse in Marfan's positive patients was 57%. So more than half of patients who have Marfan's will have prolapse. There is an important subtype of Marfan's that is still being understood, which is called the MAS subtype. It stands for mitral, aortic, skeletal, and skin. These are patients who have a Marfanoid syndrome, but they don't meet the Ghent criteria for diagnosis, and they're frequently genotype negative. And this may be a good explanation for that second patient that I presented earlier today. Two other connective tissue disorders that we have to discuss. The first one is Ehlers-Danlos, which has 13 described subtypes and many associated genes, including collagen, such as COL3A. The thing about Ehlers-Danlos is the hypermobile type has an unknown genetic basis at this point in time. And the prevalence of prolapse in Ehlers-Danlos amongst all comers is 6%. And the last one is Lewy States, which is associated with TGF-beta signaling. It is inherited in an autosomal recessive pattern. And the prevalence of prolapse in patients who are positive for this syndrome is 25%. And there's some other connective tissue disorders that are associated with prolapse, such as osteogenesis imperfecta, mucopolysaccharidosis, as well as pseudoxanthoma elasticum. There are three other non-connective tissue disorders that are associated with syndromic prolapse, the most important one being autosomal dominant polycystic kidney disease, which has a 21% prevalence of prolapse, as well as lupus and Down syndrome. So let's talk about prolapse in terms of the physical exam. So as Barlow described, patients with early or non-severe prolapse have a mid-systolic click followed by a mid to late systolic murmur that's best heard at the apex. The maneuvers that help elicit it include things that decrease your preload. So if you have the patient Valsalva or stand, the click happens earlier in systole and the murmur lasts longer. So those are provocative maneuvers that increase it. And if you increase preload rather, and if you squat or if you increase afterload by a hand grip maneuver, you will have a click that occurs later in systole with a shorter murmur. This is also shown on echo, where if you have a patient with a mid-systolic click and you do a color Doppler assessment in an apical view, during mid-systole, you may not see any regurgitation whatsoever. But when you put the same Doppler on in late systole, you will see, a good color jet. And that's important because, we traditionally think of MR as being hollow systolic. So when you look at a CW profile, it's only in late systole. So you have to be very careful when you use techniques such as PISA or ERO calculation, because you're only looking at a defined point in systole rather than a holosystolic process. And as the MR progresses with prolapse, you ultimately get a longer duration of the murmur. So patients with severe MR oftentimes will have a holosystolic murmur, and the length of the murmur signifies the regurgitation severity. Ultimately, as patients have severe MR, the ventricles has a volume overload, which can lead to progressive dysfunction. And so you get two processes that occur at the same time. The first one is enlargement of the left ventricle. And you see that on the pressure volume loops, that over time, the end systolic volume shifts toward the right. And as the ventricle dilates, the function also reduces. So the EF goes to less than 60% with severe MR. The important thing to note is they say that in patients with severe MR, a normal EF is actually more than 70%, which sounds really high, but it presents because there's 2 points at which the left ventricle can inject blood. And as that goes below 60%, that is a sign of severe MR. This is a kind of one case showing the same concept, where you have a guy with known prolapse who was followed at the Mayo Clinic over several years. Initially, he had a mid to late systolic murmur. And within 2 years, he developed a holosystolic murmur. At the same time, his EF went from 74 to 60%, and his ventricle dilated from 30 millimeters up to 42 millimeters. And at that point, he had the valve replacement surgery, or valve repair surgery, I apologize. So then the question is, what symptoms do patients with prolapse have? And this is controversial. And a lot of it's been debunked. In the early 1980s, they had this term called mitral valve prolapse syndrome. Same time that the echo was overdiagnosing patients, where they found patients who had like a lean body mass and had these vague symptoms like dyspnea and atypical chest pain and palpitations and syncope, and they had dysautonomia and low blood pressure. And they thought, oh, wow, these are all symptoms that patients with prolapse may have. Well, we now know after the Framingham study and with better population-based cohort studies that these symptoms are very nonspecific. And so they're also very vague. So the point today is that if patients present with these symptoms, they certainly need a workup, including echo and EKG, but there are no symptoms that actually reliably diagnose mitral valve prolapse. So they're very non-specific. So they should just warrant a workup. And that leads to the point that the course of mitral valve prolapse is very heterogeneous. There's many, in fact, most who have prolapse who will remain asymptomatic for the rest of their life, and their survival is similar to the general population. And they should only have conservative follow-ups if they don't have any significant MR associated with the prolapse. But if they have any risk modifiers for the prolapse, then they need close follow-up. And these risk modifiers include the following: the degree of the MR, specifically moderate to severe MR. These are patients who have high risk from the prolapse. Patients who have a drop in the LV systolic function or left atrial enlargement, as well as features such as mitral annular disjunction, mitral leaflet thickening, arrhythmia, including AFib or ventricular ectopy, as well as higher age. These are all risk factors for potentially pathologic prolapse. And that's leads to the point that in advanced prolapse cases, the mortality can be up as high as 34% annually. So it just shows how the heterogeneity, where most patients with prolapse are totally fine, but the ones who are advanced need very, very close assessment and possible valve repair. So the complications of prolapse include the following. We spent a lot of time talking about MR, which can be severe. Heart failure is an important one, most commonly secondary to MR and the volume overload associated with it. But there's some other factors that can lead to heart failure, including fibrosis of the left ventricle, as well as the presence of atrial fibrillation. Endocarditis is associated with mitral valve prolapse, but the rate is very low. In studies, the rate of endocarditis is 0.02 to 0.05% per year per patient, if they even have a murmur. The source is commonly dental, but there's no antibiotic prophylaxis that's recommended for dental procedures. And that was changed in 2007 because the rate of endocarditis is so low amongst all comers. So the risk of antibiotics outweighs any potential benefit that large populations with prolapse would have. Other complications of prolapse include stroke, as well as arrhythmias. Arrhythmias can include atrial arrhythmias, as well as ventricular arrhythmias. And then there's a risk of sudden cardiac death. That's still trying to be worked out, and it's termed arrhythmic mitral valve prolapse. The estimated annual risk at this point in time is 0.2% to 1.9%. The important thing here is that this may be an overestimate because we see patients who present, but we don't know how many actually have prolapse in the general population. John actually gave a lecture earlier this year about it, so I took his YouTube screenshot on the left. And he's specifically talking about a phenomenon called mitral annular disjunction. The picture at the right shows the transesophageal echo of my second patient who has mitral annular disjunction, which we see right here. And effectively, mitral annular disjunction, which is a risk factor for ventricular arrhythmia, is defined by attachment of the posterior mitral leaflet directly on the left atrial wall, as opposed to the ventricular and the atrial intersection junction. So it's an atrial attachment of the annulus, which can increase the risk of scar formation and is associated with ventricular arrhythmia and sudden cardiac death. High-risk features of mitral annular disjunction include the presence of prolapse, the presence of fibrosis on the MRI, higher age, a larger distance of mitral annular disjunction, more than 8 millimeters, as well as the presence of a low EF. And this picture on the right just shows a young patient with sudden cardiac death. He was previously asymptomatic, and you can clearly see he had posterior prolapse with associated mitral annular disjunction. The big thing about MAD is we don't know a lot about it. We also don't know, yet we have these risk stratifiers, but we don't know whether early repair has a significant impact on mortality at this point in time. So that leads us to transesophageal echo and the diagnosis of severe MR. Just as a review, the type of MR that we see in prolapse has the following adjectives. It can be chronic, it's chronic MR, it's primary MR, and it's degenerative MR. And the normal EF in severe MR should be greater than 70%. That's because you have afterload reduction through the left atrium, so you unload the left ventricle. If patients have severe MR, transesophageal and transthoracic echo should show the following things. You should get dilatation of the left ventricle, which is defined as a left ventricular end systolic dimension of greater than 40 millimeters. You should get a reduction of the EF to less than 60%. And then you should have a piece of radius of greater than 1 centimeter at a Nyquist limit of 30 to 40. Then you have the rule, the 4, 5, 6, 7 rule. So you have an effective regurgitant orifice area of 0.4 centimeters squared, you have a regurgitant fraction of greater than 50%, a regurgitant volume of greater than 60 milliliters, and a vena contracta of 0.7 centimeters. On TEE, you will identify pulmonary vein systolic flow reversal. That's important to note because in prolapse, you may have a very eccentric jet, so you need to look at all of your veins closely. You'll have a jet width that's greater than 50% of the left atrial area, and flail leaflet is the last marker of severe MR. I've also put the correlates for severe AR for comparison, just because these things are easy to forget. But I think the big things is dilatation, drop in EF less than 60%, and the rule of 4, 5, 6, 7, and that'll get you most of them. So then the question is, what do you do if you have a patient with prolapse, but only has mild to moderate MR and has symptoms? And that's basically what I'm presenting for the second patient. In those patients, stress echo can be a very helpful modality because it can elucidate whether the patient has a dynamic nature of their MR that might be severe with exertion. And it goes off 2 points. The first thing that affects mitral valve prolapse is contractility. So as patients have increased contractility, you actually get a greater degree of prolapse, which is seen right here as the ventricle shrinks. And the other thing is that as patients exercise, their blood pressure typically goes up. And with increase in afterload also increases MR. So exercise testing is very important. One of the caveats to exercise testing is it can actually be very challenging to look directly at the MR when patients have a high heart rate. So one of the focus of stress testing is actually to use pulmonary artery pressures identified through the modified or the simplified Bernoulli equation, where the TR, the RVSP or the PASP is equal to 4 times the tricuspid regurgitation max velocity squared plus the right atrial pressure. If you have a PA pressure greater than 60 millimeters mercury that's dynamic, that is highly suggestive of severe MR, secondary to prolapse that would need intervention. There's 2 protocols that are commonly used. The first is treadmill. You can also use supine bike. And just like any exercise stress test, you want to have the patient achieve greater than 85% of the max predicted heart rate. Additional things that stress testing provide is they give a good assessment of exercise tolerance, as well as the patient's heart rate and blood pressure response to exercise. And they can also demonstrate changes in ejection fraction with exercise. A normal increase would suggest that a patient has greater potential for improvement post-surgery. The picture to the right demonstrates exercise stress testing quite well. We have a CW that's assessing the tricuspid valve max velocity. At rest, this patient has a Vmax of 2.35 meters per second, which gives a gradient of 32 millimeters mercury if you include a right atrial pressure of 10. And when the patient exercises and achieves more than 85% of max heart rate, you see that their Vmax increases to 3.5 meters per second, which gives them RVSP of 59 millimeters mercury. So this is someone who has dynamic mitral valve prolapse, and that's important if you have symptoms that are out of proportion to the level of prolapse at rest on the resting echocardiogram. So now in our closing stretch, we can talk about management of chronic MR. There are no FDA-approved medical therapies for mitral valve prolapse or primary MR. And that's important because when the valve is the problem, the attention should be paid to fixing the valve. The big takeaway here is that mitral valve repair is the preferred strategy, and it's much preferred to valve replacement for the following reasons. Surgical valve repair is associated with lower mortality at high volume centers. That's less than 1%. If you use the following strategy, which is leaflet repair, as well as an annuloplasty band for reinforcement. The other benefits of repair besides the mortality is it avoids the prosthetic valve complications, as well as the risk of reoperation. 95% of patients remain re-op free. And the last thing is more than 80% of patients with mitral valve repair are free from either moderate or severe MR at 20 years. So there's usually pretty good outcomes if you look at the regurgitation itself. The ideal timing of valve repair is early. So if you can operate before the patient has LV dysfunction or symptoms, that's the best, and that's actually a two-way recommendation. However, if they have dysfunction or if they have symptoms, it's still proper to operate because it's better to operate late than ever. And that's why patients who have symptoms or LV dysfunction have a class 1 indication for valve replacement and valve repair, I apologize. And so the indications for surgery include the following: the presence of severe MR plus the presence of symptoms as a class 1 indication. If the patient is asymptomatic, but has LV dysfunction described by EF less than 60% or dilatation, then it's a class 1 indication to do valve repair. If they have no symptoms and have no LV dysfunction, but have a low expected surgical mortality, it's a two-way recommendation to early intervention for severe MR. In patients with an elevated PASP greater than 50 millimeters mercury, some guidelines suggest a 2A recommendation for valve repair as well as new onset atrial fibrillation. The arrhythmic mitral valve prolapse, which we contextualize in terms of mitral disjunction, the data is still like being collected, so it's not very clear if valve surgery reduces the risk of arrhythmia long term because the fibrosis may already be there, but it can be considered. Other strategies include ICD as well as catheter ablation. This study to the right is a registry-based data that shows that early valve surgery is associated with improved survival in an overall population as well as a propensity-based cohort. So fixing the valve early, even if you don't have symptoms or dysfunction, again, 2A recommendation. As far as the strategy for surgery, this is shown by this illustration. There's been a lot of improvements in surgery over time, but effectively, if the valve is a surgical repair candidate, you resect the prolapse segment, you reapproximate, you put an annuloplasty band for reinforcement for structural integrity as well as to help maximize the zone of coaptation. Now, in recent years, there's actually been some significant progress with valve surgery, including the use of robotic-assisted surgery. That's one of the newest things. So we're trying to increase the amount of patients who are eligible for surgical valve repair. One of the limitations of valve repair is if patients have bileaflet involvement, it can be tricky to repair the valve instead of replace it. But the guidelines suggest if an initial attempt should be made at repair if possible, and only if repair is not possible, then you should go to valve replacement because of the associated complications with valve replacement. The last point is that there is a percutaneous option that is now FDA approved, that is transcatheter edge-to-edge repair, which there's one brand right now, this MitraClip. TEER is currently approved for patients who have severe MR and have either high or prohibitive surgical risk. That's a class 2A indication. The picture to the left shows the technology and how we use a transeptal puncture and ultimately use the edge-to-edge repair to help improve coaptation. In terms of patients with low and intermediate risk, there is no FDA approval yet, but this picture to the right shows a study from registry data that shows that if you have successful TEER implantation, there is a significant impact on mortality. This is, again, observational data, but just it shows that if done well, it can really improve survival of patients with primary MR. So that leads to the point, well, what do we do for patients who have mitral valve prolapse, have severe MR, and may not want surgery? So there's actually 3 trials ongoing right now to compare transcatheter technology versus surgical valve repair in patients with low, intermediate, and high risk. The most important of the trial is the primary trial that's NIH funded. It's currently enrolling at 20 centers across the US, Canada, Germany, and the UK. And this is including all patients with low, intermediate, as well as high surgical risk who are surgical candidates, and randomizing them 1-to-1 to edge-to-edge repair versus surgical valve repair. And their primary endpoint is a good one. They're looking at all-cause mortality, valve reintervention, hospitalizations, as well as the onset of 2+ MR by transthoracic echo at 3 years. And they're actually using superiority design. So that's probably one of the more exciting of the 3 trials. There are 2 other trials that are currently enrolling. One is called Repair MR, which is industry funded. That's only looking at intermediate surgical risk patients. And the reason why here is because in these patients, we can't consistently deliver that less than 1% operative mortality. And they have some co-primary endpoints, including mortality, stroke, hospitalization, as well as less than 2+ MR. And this is a non-inferiority based study that's, again, funded by industry. And the last trial is out of Europe called Mitra-HR that's predominantly looking at patients that are greater than 75 years old and have intermediate risk, or if they're less than 75, they actually have high risk, and similar endpoints for that. So the expectation is that the primary trial will release data around like 2027 or so. So still several years away, but if things go well, it may give more options for patients with low and intermediate surgical risk for transcatheter therapies. So going back to our first case, this is the young male who was asymptomatic, had severe MR, and had left ventricular dysfunction. He was sent for left and right heart catheterization. His left heart catheterization showed normal coronary arteries. His right heart catheterization showed mild pulmonary hypertension with a mean PA pressure of 27. He had elevated left-sided filling pressure with the wedge of 20 and had normal cardiac output and index. So he was referred for cardiothoracic surgery, and ultimately they performed a robotic-assisted mitral valve repair with a placement of an annuloplasty band. His post-op TTE showed a drop in EF, and that's expected, as I said before, because now you only have one place for the left ventricle to eject blood, that's in the aorta. But what's more important to show is that he really had no, or maybe trace MR at best. And it's corroborated on CW, where you just don't see nearly as much MR. 3 months later, he was seen in clinic. He remained asymptomatic. He was able to walk 5 to 6 miles per day. He actually missed his echo at that time, so the repeat echo is expected in December. And the hope is that the EF is now higher than 30 to 35% because the valve has been fixed, but TBD. And then back to our second case, this was a young patient with a marfanoid-like appearance who had only moderate MR, but had significant symptoms. For him, we are actually sending him for an exercise echo, also planned for December, to better determine the severity of his MR. And he's also being sent to a cardiology genetics clinic for assessment of a possible syndromic form of prolapse. So just overall, putting it all together, mitral valve prolapse is the most common valvular abnormality. It affects 2 to 3% of the population, is also the #1 cause of primary MR. The classic exam has a mid-systolic click followed by mid to late systolic murmur. As the murmur becomes more holosystolic, the MR becomes more severe, and a maneuver that you can do to try to make the click and the murmur earlier is to decrease preload, so Valsalva or standing. In terms of the two forms, the most common form of prolapse is the primary form, that it has no extracardiac manifestations. The secondary form is associated with connective tissue disease. The one with the highest prevalence is Marfan's, where you're looking at almost more than half of the patients with Marfan's have prolapse. In terms of diagnosing prolapse, we use a transthoracic echo. The limitation of the transthoracic echo is you really only get a good assessment of the posterior leaflet, predominantly the P2 segment, and we define it as a systolic displacement greater than 2 millimeters mercury, 2 millimeters, sorry, into the left atrium during systole. If there's high concern or high-risk features on transthoracic echo, we send patients for TEE as well as potentially MRI. These are highly sensitive modalities. MRI gives a benefit of also looking at volume as well as scar formation. And if you're unclear where the patient has a high predisposition to having MR but doesn't have significant MR, stress transthoracic echo can be very helpful. The prognosis of prolapse ranges very widely. Most of these patients with prolapse remain asymptomatic for the rest of their life. But if they have significant MR or complications, things can go bad. And so these complications include MR as well as heart failure, arrhythmias, sudden cardiac death, stroke, as well as endocarditis. And then the management is repair. The issue here is the valve, so you have to try to repair the valve. And so indications for valve repair is patients who are symptomatic or those who are asymptomatic with LV dysfunction or dilatation. Those prophylactically, if you have a low expected surgical mortality, less than 1%, you send them to surgery before the dysfunction occurs, as well as things like pulmonary hypertension or atrial fibrillation. If patients have high risk for surgery, transcatheter edge-to-edge repair is FDA approved if they have conducive anatomy, and we'll have some other trials that are ongoing right now to look at transcatheter edge-to-edge repair in lower risk groups. So with that, these are my resources, and I'm look forward to any questions that people might have or comments.
Thanks, Rahul. That was a very thorough review of mitral valve prolapse. Really appreciate it. I noticed in the chat that Dr. King mentioned a paper about ventricular buckling associated with mitral valve prolapse. And Dr. King, I wondered if you would mind talking about that.
Yeah, this was a terrific presentation. It's amazing how much has been learned from echocardiography in the interim. But this was an old paper before echo was available. It's based on hemodynamics and angiography. But these were patients who had ventricular arrhythmias, quite serious ventricular arrhythmias, and it's a lot of things were concluded. But the hypothesis here is that the billowing prolapsing valve pulling on the chordae and papillary muscles was creating ventricular abnormalities and ventricular arrhythmias. And we didn't know about the high implantation of the valve that are somehow now associated with ventricular arrhythmias. But if you can find that paper, you'll see some very interesting, it may be hard to find, but you'll find some very interesting angiographic images showing that the papillary muscle is being wrenched up by the billowing posterior leaflet, and we think we documented that was the source of the arrhythmias. Just for your interest, if you can find it.
Yeah, I look forward to checking that out.
So I knew Dr. King would pipe up because in the 70s and early 80s, there was a lot of work done here by Dr. King and Dr. Cobbs on this entity. Number one. Number two, you know, I've found that like Carpentier classification and seeing, quote, Barlow's disease, and I don't think Dr. Barlow ever knew that he would have a disease named after him. He passed away a long time ago, but there's a lot of overlap here. And if you take Barlow's disease, quote unquote, and you take P2 prolapse, they seem quite different. And why do you get P2 all the time? Well, sometimes we see P1, sometimes we see P3, but mostly it's P2. Probably something about the hemodynamics of and the anatomy of the P2 segment. But I think I like that you showed the stethoscope, because we ought to first start out with the stethoscope and diagnosing mitral valve prolapse and standing up. I love to stand them up and listen for the click. And I found that most people get well into their fellowship before they know about clicks and actually have the opportunity to hear a late systolic mitral click without a murmur and stand them up and hear the murmur. So, and then it's interesting to read about where the term mitral valve prolapse came from, because when Dr. Barlow was investigating that, he was trying to prove that this mid to late systolic click was not an extra cardiac sound, because it was thought that this was an extra cardiac sound. And so he comes up with the idea that it's coming from the mitral valve. So he writes a paper on it and he sends it to circulation, and circulation turns him down. Then he was invited up to Hopkins to the genetics clinic, and he presented it there, and everybody was interested in it. And there was a young fellow or faculty member in the audience whose name was Michael Crowley, and he heard the presentation, and he said, well, we see this all the time in the cath lab. And he said, I'll show you one. Took him back in the back and showed him a ventriculogram and someone with P2 prolapse. And so we call this mitral valve prolapse. And Dr. Barlow had been calling it a billowing mitral valve. Of course, he had a lot of things mixed in there and hadn't had the opportunity to study it as it has been studying now. So somehow the term mitral valve prolapse is hung on, and even to his death, Dr. Barlow was calling it a billowing mitral valve. So in the genetics clinic, why am I blanking on the person's name was there? Anyway, he was the editor of the Journal of Chronic Disease. So he said, well, you need to publish this, Dr. Barlow. So Dr. Barlow said, well, I've submitted to circulation, where you were on the editorial board and you turned me down. He said, well, I'm the editor of the Journal of Chronic Disease, and we will accept your paper right now. So you'll find the first reference in the Journal of Chronic Disease referring to the mitral valve, billowing mitral valve as seen first by Dr. Barlow. So that's how the term mitral valve prolapse came about. And I actually talked with Dr. Crowley about that, and he confirmed that was a story. And that's written up in circulation. If you look far enough, you'll find that. So that was a great presentation. It was extremely extensive. And congratulations on that. It's everything we know about mitral valve prolapse, including the genetics and the microscopic findings.
Thank you, Dr. Clements. I appreciate that context. That's very helpful to know. Clearly not an extra cardiac sound.
If we don't have any other questions, we're kind of right at the top of the hour. We'll wrap up. But Rahul, again, really great job. Very thorough presentation, one that I'm sure we can all refer back to going forward. So I appreciate it. Happy Friday, everybody, and have a great weekend.
The preceding program is copyrighted by Emory University.